Just share your slides, Dr. Jovita.
Yes, sir. Yes, sir.
Welcome to this session of ISC Kerala PG Clinics. Today the faculty are Professor Narendranathan M. and Professor Ismail Siad. Professor Narendranathan is well known to you. Professor Narendranathan is the former head and professor and head of gastroenterology of Government Medical College, Thiruvananthapuram, and currently he is a senior consultant of Cosmopolitan Hospital, Trivandrum. Sir has taken many clinics for you. Apart from the clinical interest, avid researcher, and Sir has interest in statistics as well as epidemiology. So he has, apart from MDDM and MPH in public health as well. Dr. Professor Ismail Siad has been is the current senior consultant of Asta MedCity Kochi. He has been with Amrita Institute of Medical Sciences earlier and has worked as a professor of gastroenterology there. Moderators are myself and Professor Jayanti now, and as a special guest, we might have the presence of Professor Shobna Bhatia, formerly from Mumbai. Now she is working at Jaipur. The presenter today is Dr. Jovita Preeti from Medical Trust Hospital Kochi, and the discussants are Dr. Parag and Dr. Krishna Kumar. Over to you, sir.
Sir,
Okay. Jovita, go ahead.
slides visible, sir.
No,
Yeah, visible. Can you put it in full screen mode? Just click this full screen mode on the bottom part
Yes,
of your.
It's not
Yes,
coming.
Double
She's
click,
clicking.
double click.
Yes, it's full screen.
no.
Sir, it's full screen, right?
No.
No,
Either you can put a view, click on the view and then put full screen, or double click the full screen mode at the top.
yeah, click on that.
You
The
just
same
leave
slide.
the slideshow.
It's
Open the view.
Is it full screen now, sir?
No,
No.
Sir, I have done full.
Today I also saw having little bit of
Press
problem.
F5. Press F5.
F5, F5.
F5.
But I think it is big enough. If it is not possible,
yeah, we can continue.
you
I have the
can try.
slides with me. Jovita, if you are not able to do that, I will show from my side.
It's okay.
So is it okay?
No.
Sir,
Say,
move the
but
slides, sir.
we can see the slides. It's okay.
So shall I start then?
Go ahead.
I think
59-year-old male, Mr. S, was working as a binding machine operator, now retired since 6 months and presently working in a farm. Studied up to 10th standard, coming from Kochi. History taken from the patient himself and history is reliable. Presented with complaints of vomiting on and off since 1 year, more since 1 month, postprandial abdominal fullness for 1 year, loss of appetite and weight for the past 1 year, feeling of lump per abdomen for the past 1 year. He was admitted on June 9 as his symptoms were aggravated from May 1st. Patient was apparently normal 1 year back, except for hypertension, for which he was on medications. History of
The slide didn't change.
You can move the
Slide did
You can click with your mouse on the HO.
Yes, sir.
the slides have gone off. Oh yeah. Now it's
Full screen, I think. Okay.
So has it been changed?
Yeah.
Patient was apparently normal 1 year back, except for hypertension, for which he was on medications. History of vomiting on and off for the past 1 year, which increased since past 1 month. It occurred once in 4 to 5 days initially, contains stale food, and last day and
Voice is breaking.
associated with nausea, not blood or bile stained. Since 1 month, it's more frequent, happening once in 2 days. Postprandial abdominal fullness for the past 1 year, more since last 1 month. Associated with increased gastroesophageal reflex for the past 1 year, not associated with abdominal pain, for which he used to take on and off over-the-counter medication, pantoprazole, and had some relief temporarily, which with recurrence of similar symptoms, aggravated after food intake and relieved with vomiting. History of ball rolling movements present, more postprandially. Loss of appetite since 1 year. History of loss of weight, 8 kg in the past 1 year. There is a sense of lump per abdomen for the past 1 year over the upper abdomen. Felt as if the size has increased from size of a lemon to that of a cricket ball. No history of melena or hematemesis. No history of palpitation or dyspnea on exertion. No history of dysphagia. No history of prior corrosive injury. No history of cough, fever, or night sweats. No history of yellowish discoloration of eyes or urine, dyspnea or backache. No history of diarrhea or generalized abdominal distension or constant abdominal pain. Past history. Known case of hypertension, was on tablet telmisartan 40 mg once daily. No history of previous abdominal surgeries. No history of similar illness in the past. Not a diabetic. No tuberculosis. No history of chronic NSAID intake. He had a history of kidney stones 30 years back. Took homeo medication for 1 month for the same. Personal history. He is a smoker. Smokes BD 1 pack per day for the past 30 pack years. Started consuming alcohol 2 to 3 peg brandy per week for the past 2 years. When his son had an RTA, cage 2x4 and audit C6. Stopped alcohol since the last 9 months. Diet, he is consuming mixed diet. Pre-morbid, 1 year back, the calories were 2,300 and protein of 60. Now it's 1,100 and protein of 30. The deficit, calorie deficit is 1,200 and protein deficit of 30 grams. Sleep is normal, normal bladder habit. Since last 2 weeks, he is having heart stools. Family history, his father expired at the age of 90 years with pneumonia, and mother expired due to old age related, not exactly known what is the cause. And siblings both are healthy. No other family members had GI cancers or other major GI illness. He's married, having 2 boys. Both are healthy. Lower middle class socioeconomic status as per modified Kupsami classification. Treatment history, he had over-the-counter antacids on and off. Never had any treatment or prior endoscopic procedures for these complaints. No previous history of GI surgery. Summary. So can I?
Because before going to summary, sir, shall I clarify some doubts?
Yeah, okay. I think let us just finish this summary
Okay.
and the diagnosis, and then we will go to Dr. Ismail. Yes, what is the summary?
Okay, sir. A 59-year-old male who is a chronic smoker with 30 pack years, hypertensive, presented with 1 year of vomiting, which is non-bilious, large volume, stale food, postprandial abdominal bloating, anorexia and significant weight loss, with an epigastric lump which has increased in size, ball rolling sensation, increase in symptoms, since 1 month with ECOG performance scale of 1 and WHO performance status of 1 and lower middle class as per modified Kupusami scale.
So your diagnosis from the history?
Syndromic diagnosis is gastric outlet obstruction. Considering significant weight loss and anorexia and age, probably malignant etiology, probably CA stomach of the anthropyloric region causing obstruction without any evidence of distant metastasis and without evidence of GI bleed as per history.
Okay, let us listen to Dr. Ismail. Dr. Ismail.
No, I just want some clarifications. When you said presenting complaints, all your presenting complaints like vomiting, postprandial fullness, loss of appetite, everything is 1 year. So did everything started simultaneously, or there is some difference in the duration of symptoms?
So he had a long duration of symptoms for 1 year, and what he told is
okay.
almost everything.
But when you were presenting us, you said everything for 1 year.
Yes.
So did all the symptoms started simultaneously? There are 4 or 5 symptoms which you have elaborated.
Yes.
You said it's all 1 year. So did it start simultaneously, or there is a difference in the occurrence of symptoms?
So he had, when I asked, it was told that everything started almost simultaneously.
So was it started? Yes, sir. Sure.
No, initially the vomiting was once in 4 to 5 days. Slowly it progressed, and then it once in 2 days.
But even during that time, did he have postprandial fullness, pain, lump?
Initially the lump size was small, and later on the size increased.
Your voice is breaking.
Okay, yeah. Can you stop sharing? I'd like to show some of my. Can you stop?
Jovita, can you stop staring for a while?
Okay.
Yeah, I would like to. No, from the history itself, I would like to. It's not coming now. Yes. So I think it is still, yeah. I just give a short. The content, I think the content of the history, it was very clear. Everyone can imagine in their mind the man who presented with features of gastric outlet obstruction. So that was good. Second is the slides, I think because of the black and white, the black color and a white background, I think the contrast was good. And in a Zoom meeting, even the slides, those things were okay. But but I think the multimedia and figures and all you may introduce in the examination. One of the things which, but I think if you had avoided many of these negative points, you could have made the slides look better, but I think that's fine. And then the time also, I think you took only the enough time needed. But what about the language of the presentation? If I take this, for example, take this sentence. Last day's dinner, undigested food particles and mucus. The vomitus contain, is there anything wrong with that? So I think what I would like to present here is that you see that food FOOD and mucus MUCOUS. Now, one of the things that, can you see the title mucus or mucus? You know that now this is a snail, it secretes mucus from a mucus gland. So mucus gland, the spelling is MUCOUS, and it secretes mucus, it is MUCUS. So mucus, MUCUS is a noun and MUCOUS is an adjective. So the correct would be omitted. So the mucous membrane secretes mucus. The correct spelling would be MUCUS. I also found a lot of spelling mistakes like, the associated was wrong, and I think relieved was wrong, and possibly that, but I think we need not take it very seriously. But as a gastroenterologist, it may be better to know what is mucus noun and mucus adjectives mean. And I think one of the things is that you should pay attention to the details. It is attention to the details that makes the difference between an average and a stunning presentation. So I think that if there is a look at the spelling, and then one of the other things that I noticed is that you have mixed the UK spelling and the US spelling together. But in a presentation like this, it may be okay. But when you are presenting in a conference or when you're presenting to an audience, always make it a point. Or when you're writing an article, don't mix these spellings. Like Melina, you said MELENA, but color is COLOUR. So I think always stick to one type of spelling. So how can you overcome that? This is what is called as, you can subject your presentation to what is called as a colleague treatment. I'm not the smartest fellow in the world, but I can sure pick smart colleagues. One of the things you can do is that you can take some of your colleagues into confidence and show them. And I think they are, because you have been busy writing all these things, so small spellings and things like that you may overlook. But you can always ask some of the colleagues to look in and they will point out. So always, if you are going for a presentation in a conference or something, it is a good idea to give what is called as a colleague treatment, which they will look into and take it carefully. Now, let me go into a little more detail into some of the things that you said. For example, you said,
sir, there's a complaint in the chat box that people are not able to hear. Are you able to hear me?
I can hear.
can you
Jovita, can you hear me?
Yes, sir, I can hear you.
Okay, there are many people saying that they are not able to hear. I don't know what's the
is my
problem. Okay,
voice
sir,
audible?
continue.
Is my
Sir,
voice,
continue.
Sir,
is my voice audible?
Yes, sir.
Yes, okay.
your
Now,
voice is audible.
yeah, I think now one of the things that you said about the cage questionnaire. No, this is like the John Hopkins healthcare, their pamphlet shows that it gives you an information about whether substance abuse exists and needs to be addressed, whether it exists now. But you have said that this person stopped alcohol 9 months back. When a person stops alcohol 9 months back and now you say apply the cage questionnaire, it's not what cage is meant for. So another thing is that the audit test you said about the score in an audit test. If you look at the alcohol use disorder test, is an alcohol screen that can help identify patients who are hazardous drinkers or have active alcohol use disorders. This person stops alcohol 9 months back. So cage questionnaire and audit questionnaires are not the one for him. So I don't think that you should put so much emphasis on that thing.
And moreover, sir, 1 second. Moreover, you can see that it's only 2 to 3 packs per week.
Yeah, it's not per week. Yeah, that's not such a serious disorder. Okay, now coming to the history of food intake, you said that 2,300, 1 year back, 2,300 was the calories. But you know that food questionnaire, you have done a very difficult job and analyzing the calories and all. But you know that when you do a food recall questionnaire, usually it is 1 day or let's say 24-hour recall, or you go for a, but you have gone for 1 year recall. Huh? It's tremendous. Then 1 year back, 2,300 calories. So it's either it is plus or minus 1,000. So I think that and many people overestimate the calorie intake in a questionnaire. So in a questionnaire like this, I know you put a lot of effort to calculate this, but going 1 year back and getting the calories for a questionnaire is not the ideal thing. And you may not use this in the bedside or even in the when you are presenting this case, in a bedside or in an exam, you won't use this type of questionnaire. And you should know that many a time when you calculate calories in a questionnaire, it is usually overestimated. And then many people underreport the food that they take, especially women. It has been shown that. So in this situation, I don't know whether we should have a serious discussion. I think that we would stop it there and may not go much into the details of this thing later on. So I think that is there anything else? Anyone else would like to say anything? Ismail or something? Ismail or anything? Any comments from our?
One more thing, when you said about lump, actually from some lemon to a cricket ball and all, you should also specify what sort of, whether it is you said that he has the feeling of lump, whether he actually can feel it And if you can feel it, what is the consistency of the?
He felt
Because
it.
because the sense of a lump and feeling of a lump is different.
He felt the lump, sir.
Pardon?
Okay.
He felt the lump. He could feel the lump.
Yeah, okay. And then I think from the history, there are other things. Dr. Parag or someone is there. What do you think from the
Yes.
from the history? Anything else that strikes you from the thing? No, they gave a history of. What do you think about the history of taking telmisartan or urolithiasis? What do you think about telmisartan, and also do you anything that you know about?
May not be relevant to the case, sir.
No, I think that I will show you one. I think this is gone, no?
You can.
Okay, this is this is a paper which was published recently about 10 years back, in 2010, about the ameliorative effect of, telmisartan is an angiotensin converting enzyme inhibitor, and so it plays an active role in inflammation. And people have shown that in indomethacin induced ulcers in rats, telmisartan does have prevent ulcerations, and it has been found that if you look at the third bar, that is in diabetic rats with telmisartan and indomethacin, the ulcer index is very low compared to diabetics with indomethacin alone. So telmisartan has but I think we may not use it because it will reduce the blood pressure also. But this is something about telmisartan because it's an angiotensin converting enzyme. Anything about urolithiasis, and is there anything which links urolithiasis with stomach and ulcers or anything? Anyone would like to comment on that? Parag, and who is the other person who was there? Krishna Kumar. Krishna Kumar, would you like to say any relationship between urolithiasis and ulcers and things like that? Krishna Kumar, are you there? You can unmute, and you know that there is a very interesting study which is, that there are normal bacteria in the intestine called Oxalobacter formigens. These Oxalobacter formigens uses up the oxalate and prevents the oxalate from going into the stream. And it has been found that Helicobacter pylori, when it colonizes, the concentration of Oxalobacter formigens comes down. So that there is more oxalate is sent to the systems, and that is one of the explanations given for more stones seen in persons with the Helicobacter pylori infection. So even though in passing she mentioned about telmisartan and about urolithiasis, there is a relationship with some studies showing that Helicobacter pylori may be associated with increased urinary stones. You may also have heard that Helicobacter may produce some type of ulcer called the Hannen ulcer or something in the bladder, and then it can lead to the stone formation. So there is a relationship between Helicobacter pylori and urolithiasis. That is what I just wanted to mention. Okay, now you can stop sharing the screen, and then okay.
There is some more association, sir. Hyperparathyroidism.
Oh, go ahead.
Some more association. Basically, hyperparathyroidism can produce hypercalcemia, increased acidity, ulcers, urolithiasis.
Yeah, urolithiasis. Okay, that's the hypercalcemia. It's called the disease of stones, bones, and abdominal groans. That's what people call hyperparathyroidism. Any other thing that you would like to discuss or anything?
Can we just go through the summary once again? Javida, can you upload
You said there is no metastasis. Now, how can you say there is no metastasis from the history?
So there was no, history-wise, no back pain, no dyspnea, cough. So lung mets, bony mets.
You can go to your slide on the summary. But I think that's a mistake that you should never say from clinical examination that a person doesn't have metastasis. You should never make. I think that that inference should not be made. You can make it full screen, and then so I think that you cannot say without metastasis. Many a time you find metastasis even sometimes only in a PET scan or something like that. So looking at a person with an outlet obstruction, you cannot say that there is no metastasis. And another, what is the commonest cause of gastric outlet obstruction in a What is the commonest cause?
Most common causes are benign.
Is it? Who said
Benign
so?
more than malignant.
Who said so?
Yes.
And I think let me just show an article. Can I share the thing?
Yeah, you can share
Can
some.
I
Then the other one go
share the
away.
thing?
Once you share, the other thing should go away.
Yeah, okay. Well, it's not. So this is a paper from India, no? Malignancy is the most common cause of gastric obstruction, even in a developing country. This is SP Mishra, you know that, no? Allahabad is a, so the malignancy is the most common cause, even in a developing country. So even there are studies, even in from outside, showing that in a person comes with gastric outlet obstruction, malignancy is the most common cause. It was when we were students, the pyloric stenosis was very common. People used to come with ulcers. But now with the proton pump inhibitors coming, it has changed the thing, all right. It has changed the presentation. So now, this was in 19, it's very long back. This is not a new article. But I think that, so they say that malignancy, and even from West, they found that a person who comes with about 40 to 50% of cases of gastric outlet obstruction are due to malignancy. So I think that is the most common cause of gastric outlet obstruction. That's something that you should know about it. Okay. I will stop sharing, and I think you're okay. Parag or some any comments from Dr. Parag or Dr. Krishna Umar?
No, I just want to ask Dr. Jovida, what are the points in favor to say that there's a gastric outlet obstruction? You have said gastric outlet obstruction. Can it be simply gastroparesis? How do you differentiate gastroparesis from outlet obstruction?
So there is weight loss and anorexia, and epigastric lump is felt.
No, that depends upon the etiology, no? Okay, just now Narendra sir told the most common, most likely possibility is a malignancy, and then you can expect other symptoms. But pakka gastric outlet obstruction versus a gastroparesis, can you clinically differentiate?
Non-bilious vomiting.
No,
Gastroparesis fundamentally it is the paralysis of the antral contractions mainly, and some degree of relaxation of the fundus and body. But in a outlet obstruction, if the patient is able to feel the bowel rolling sensation and the peristalsis, all those things the patient is able to feel, it obviously tells that the stomach is trying to overcome the obstruction by vigorous peristalsis. If that symptom is there, for your own physical examination, if you find vigorous visible gastric peristalsis, VGP, then that's also is a point against a gastroparesis. Okay.
Okay.
But apart from the clear stomach, what are the other possible causes of
Outlet obstruction?
Outlet obstruction.
Differential CA stomach or CA from the body of the pancreas, if it's malignant. Then gastric lymphoma, gastroduodenal tuberculosis, peptic stricture, down the list.
I think better to divide it into benign and malignant. So
Benign
we'll have a clarity of concept and tell the most important causes which are seen in clinical practice. That way, you will be technically correct most of the time. But if you just a random list of various etiology, immediately the examiners will catch you and say, how often you see like that. So important thing should come first. So have a classification in your mind. Tell, okay, malignant ones, benign condition.
Mainly CA stomach, then carcinoma of body of pancreas.
Body.
Because if it's head, then they may present with jaundice, because there is no jaundice in this patient.
How does body neoplasm present outlet obstruction?
By compressing the extrinsic obstruction of the or infiltration.
I think extrinsic obstruction, when to produce obstruction, the luminal compromise must be quite significant. Okay, anatomically it is not, the body is not close to the narrowest portion of the stomach. Okay, then Probably if the body, it is likely to be infiltrating into the third part or duodenum and then causing obstruction. That would be more technically likely. Okay, no, other than it can produce obstructive jaundice most of the time, but sometimes it can produce obstruction just below that region and produce duodenal obstruction. So duodenal obstruction either from the head or body. Then you said something else. CS stomach, you said duodenal
Gastric
obstruction.
lymphoma. Gastric lymphoma, malignant.
I think one of the comments made by Dr. Jayanti is actually very relevant because she has mentioned that a ball rolling sensation is not common with malignancy. I think that's true. And then 1 year history. And that's also, I think, is very unlikely to be gas malignancy. A person has been having vomiting for last 1 year, and we are saying that it is cancer. No, it is, even though it is a common 1 year is too long a history to say that a person is having malignancy, 1 year and then that I think, what do you think?
Yeah, that's an important point, sir, because once we say that there is outlet obstruction, that means there is a significant obstruction of the anal outlet. Okay, and then the patient having intermittent symptoms would be difficult to explain.
Okay.
And large volume. Large
Yeah.
volume is uncommon.
Yeah, gastric, yeah, because it doesn't distance that much. Yeah, okay.
A very large volume of vomiting is also not a point in favor. Okay, great. Because the stomach doesn't distend. Why, Jovita, stomach doesn't distend much in malignant conditions?
Because of infiltration.
Okay, yeah, infiltration, and then extension upwards. Even if it is in the antrum, it may even reach up to the cardia. No? When we do endoscopy, very often we find that the lesion is reaching, or even on a CT, we can find the lesion is reaching up to the cardia. Okay, your benign contention, have you finished?
She has some DD, I think. You can show your DD.
Septic stricture or pancreatic pseudocyst.
Okay.
Then large subserous just extrinsically compressing. Leiomyoma.
Benign tumors. Okay. Of the stomach. Is there any condition of the stomach where you can have intermittent pyloric obstruction? If there's a polypoidal tumor of the antrum, it can actually sort of fall into the pylorus and into the first part of duodenum, produce obstruction, and then get back like that. Polypoidal tumors with the pedicle, long pedicle, can produce this thing. Very rare case reports.
Yeah, I think there is a diagnosis. You can show the thing. Your next slide is DD. No, you can make it full screen and show your next slide.
The next is examination.
Okay,
Yeah,
can we ask the other participants?
Make it a full screen.
There's a DD slide.
Make a full screen, yeah.
Sir, actually, I have made it full screen.
Then I think you can take next.
Move to the next
slide. Next slide.
Yes, sir.
You're not able to.
It's not moving here.
Just stop it, stop sharing and reshare. Then it will have work.
Yeah.
Meanwhile, we'll ask the other two discussants their differential diagnosis as per the history.
Yeah. Dr. Krishnamar is not seen outside. Okay.
Yes, sir. Yes, I am here, sir.
Okay. Anything you have to say about this?
Sir, my first DD is I'll keep carcinoma pyloric antrum as first DD, sir. Followed by gastric diffuse large B cell lymphoma second, and then peptic stricture.
I don't think examiners will agree to your CA stomach. What's the natural history of CA stomach? What will be the natural history survival without treatment?
1 year survival.
This is 1 year with obstruction. Presented with obstruction 1 year back.
1 year.
Yeah, and he has been going around, so it's a
5%.
pill to swallow. Yeah.
They will no one will accept a CA stomach as a DD.
Yeah, finally, I know that the presenter knows the diagnosis, but from the history, I think to say that for 1 year a person is having carcinoma of stomach becomes a little difficult. So go to the physical examination. Okay.
Physical examination. The
If
patient.
you were 1 minute, if you were to revise the diagnosis and we say it's not CA stomach, can you relist the differential? Cicatrized duodenum, no? Cicatrized duodenum, that's the first DD. That will be number
Peptic
one.
stricture.
That will be number
Peptic
one.
stricture. Okay.
Not
Yes,
peptic
so
stricture.
perhaps.
Just a cicatrized duodenum due to duodenal ulcer. That will be number one. Number two, it can be tuberculosis. It can be Crohn's. They're all we're talking of lesions proximal to the ampulla. We've seen lymphomas, can have Crohn's disease. You can have any of these causes that is proximal to that. You may have bands. So, supposing I say it's adult hypertrophic pyloric stenosis. What's your comment? Sorry, sir, I joined late. I went for a walk, so I can.
Oh,
Adult hypertrophic pyloric stenosis?
Should have pain in abdomen, ma'am, which is not there.
No, they don't have pain. They're just present like this. What is the most important thing? You'll feel a lump, olive like mass.
and
Patient,
yeah, there is a mass here in this patient. No?
patient.
He says that he's feeling a mass, no?
Yes, sir.
Yeah, but I think that they may distended stomach, they may say it's a mass. So I
Okay.
think that we cannot, based on a person's patient, you cannot say that it is a mass or a distended stomach. It may be difficult for them to differentiate.
And
But the
pancreatic
description is not like
sir.
of a distended stomach, sir.
Distended stomach, yeah, that may be mistaken as a mass, no?
Yeah.
No, but the description is not of a distended stomach.
Oh,
Yeah.
it is, they said that it was
Lysis
formation.
And pancreatic pseudocyst cannot come as a DD in this patient. Absolutely. 1 year vomiting, pancreatic pseudocyst will not come as a DD. Okay, continue.
Continue, okay, physical exam, yeah.
Patient is conscious, oriented, cooperative, comfortable at rest, thin built, ill nourished. Patient is kept nil per oral and he's on RT aspiration since 1 day with a peripheral IV line in right forearm. The RT aspirate is yellowish to mucoid and contained 300 ml on examination. Vitals were normal. Height of 170 centimeter and weight of 50 kilogram, BMI of 17.3 kilogram per meter square. There is no pallor, no icterus. Clubbing was present grade 1, no lymphadenopathy and no pedal edema. Tobacco stain was noted in teeth, lips, palate and both hands and nails. Thyroid, no swelling. Palmoplantar thickening and hyperpigmentation was present. There was no acanthosis, nigricans or seborrheic keratosis. There was supra and infraclavicular hollowing and temporal hollowing. Mid-arm circumference was 18 centimeter. There was no signs of micro or macronutrient deficiency or fat-soluble vitamin deficiency. There were signs of dehydration like dry skin, coated tongue, and poor skin turgor. Systemic examination. On inspection, fullness was seen in the epigastric region while looking tangentially from the foot end. Almost 4 into 3 centimeter, moves with respiration. Skin over the swelling was normal. All quadrants moves equally with respiration. Scaphoid abdomen.
Fullness
Umbilicus
is
was
moving. Huh? Fullness is moving. Fullness is moving up and down. What is it?
during
Is it-
respiration that
The fullness is moving. Huh? Will you describe it like a fullness or you think it's a lump?
lump.
Is it a mass that's moving? Fullness is what's the meaning of fullness? Just be careful, okay, when you're describing. Okay, continue.
Umbilicus was normal in shape and pushed slightly downwards. There was no visible gastric peristalsis. Hernial orifices and flanks appeared free. Skin over the abdomen was normal. There was no scars, no sinus, no dilated veins, no scratch marks or nodules, no divercation of recti. Carnet sign, swelling.
You look for scars in this, you look for scratches in this patient. Oh? You look for dilated veins in this patient. You spend time looking for all this?
No scars.
No. Will you spend time looking for scratch marks in this patient and dilated veins?
No.
What are the important things that you look for in inspection of this patient, doctor?
Is there any nodule?
What just 2 or 3 things that are absolutely important in this patient. One is fullness. Number 2, VGP. Number 3 would be the umbilicus and any distinction, that's all. So be careful when you're describing, no, in the exam.
Okay.
Please don't say no scratch marks, no dilated veins. You cannot see anything aimlessly, no? Without an aim, what is in your mind is what you will see, okay? You will see only what is in your mind.
Yes.
If you're doing as a routine, you're likely to miss the most important findings, right?
Okay. Carnet sign, swelling appeared less prominent on head raising. And on palpation, a well-defined hard mass of 4 into 4 centimeter felt in the epigastrium. Skin over the swelling was mobile, could insinuate finger all around the swelling. There was no intrinsic mobility. It was not pulsatile, not warm, not tender, and other areas were soft. Succussion splash was present. Epigastrium to umbilicus and umbilicus to pubic symphysis. The umbilicus appeared pushed down in midline. There was no palpable liver or spleen or gallbladder, no periumbilical nodules. Hernial orifices were free. External genitalia and parectal examination was normal. On percussion, there was no ascites. Dull note felt over the epigastrium. Other areas were tympanic. Trough space was resonant. On auscultation, bowel sound present. Other system examination, CNS normal. Respiratory system bilateral errantry present. CVS cardiovascular system, heart sounds heard. No venic murmurs. Gait normal. Skeletal system, spine and cranium appeared normal.
Before going to the investigations, what do you make out from the? Have you any difference in after the history you made a diagnosis? So after the examination, are you making any other? Is there anything different? Can I share the screen? Can you stop sharing the screen? I just wanted to.
You can override.
I think there is something that I wanted to tell you. Now, from where did you get this Carnot sign? From where did you get this Carnot sign? Did you read about it or someone told you about it?
Read about it.
From where?
And during medicine examination.
Dr. Parag, do you know what is Carnot sign, or Dr. Krishna Kumar, do you know what's Carnot sign was, I think this is your paper, is it? No, this is mine. But look at the systemic, yeah, that is Carnot sign. No, I think you should know a little bit about Carnot sign. Carnot sign was described in 1926, I think, by John Burton Carnot. It is about pain, it is not about lump. I don't know where you got this message. It is not for differentiating intra-abdominal or extra-abdominal lump. It is about pain. See the thing, this is the first article that he published, pain and tenderness occur, and it's about the pain. So he says that you can differentiate whether the pain is from the anterior abdominal wall or from inside by doing the Carnot sign. So I think let us know, this is the Carnot sign. So a palpate site during flexed abdomen. If increased pain, source is likely abdominal wall. If no increased pain, the source is visceral. So Carnot sign is used for pain and not for lump. So when you say that the pain is increased, you know it is from the abdomen. So similarly, I think you can have a leg lift or chin test. So that's not Carnot sign. So I think that I think you might have picked it up. I think someone asked VK Krishnamenon. Do you know who is VK Krishnamenon was? Do you know who is? No. I think so. Some Englishman asked him, "Why do you speak so good English?" Then VK Krishnamenon said, "I didn't pick up English from the streets like you." Now, what I wanted to say was that when these things are there, pick these things from the books or from the teachers, or not for as someone heard, told it, and then don't present it saying that it's Carnot sign and things like that. There is a sign to differentiate an anterior abdominal lump from a visceral lump. This was called by Fothergill sign, but this is to differentiate the hematoma from the rectal wall from that is inside. So this is the palpable tender abdominal wall mass that does not cross the midline and remains palpable when the rectus muscle is tense. Is suggestive of a rectus sheath hematoma. It doesn't mean something inside. So when the lump becomes tense, it is from the rectus sheath. So please look up Carnot sign and see that as Carnot sign is about describing the pain. And when the abdominal wall is tense, then the pain increases. It's an abdominal wall pain. And when the pain doesn't increase, it's possibly from lower down. So I think it is not Carnot sign that does so. Okay, then let's go about the, I will stop sharing. Let us go to your, anything else? Anyone else would like to, doctor, from the physical examination, can we go to the lab test, to the test?
Jovita, can you just summarize the positive findings?
Okay, sir.
Just positive findings. No, from, no, you know it, no? So just,
Yes, sir. There was mucoid as RT aspirate, almost 300 ml. And there was significant, the BMI was low, 17.3. And there was tobacco stains. There was a palpable lump over the abdomen.
no, you are palmoplantar thickening and hyperpigmentation. So there's a thickening of the skin of the palms as well as the feet as well.
Yes, sir.
Palmar, plantar also.
Palmoplantar.
So many
Oh.
laborers have, I think, thick.
Yeah, profession is important. What is his job?
Farmer.
Palm.
So it's quite possible that it is due to his work related. Okay. Otherwise, suppose he is
What is the
having a sedentary job and then still he has got a palmoplantar hyperkeratosis.
Can be a
What?
parentoplastic.
Of what?
And what will be the source of neoplasm? Which site?
The esophagus.
Okay, good.
Yes, that is, yeah.
The otherwise known as stylosis, no?
It is.
Go ahead, yeah.
And supra and infraclavicular hollowing. All
The major findings. We should not get digressed by minor findings. Concentrate on major findings. Okay, low BMI agreed.
then
Mass movable or
mass was there, which was moving with respiration.
upper abdominal mass, no, epigastric
abdominal
mass, 4 into 3, movable.
Movable.
4 to 3 is a small one. What do you think that mass is?
Can be the mass of tumor per se.
Which organ?
Stomach.
Can it be anything else?
Can it is a localized mass. Could be insinuated all over the swelling.
No, what do you mean by insinuation? That means you can go alternate.
Suppose I say it is a left lobe mass.
So insinuating the finger is a very tough physical sign, I think.
I know.
Your surgical colleague may be your friend, so you are easing his job, is it? By insinuating your finger around the lump. I found it nice. You are able to insinuate the finger all around the mass. I thought it was not a good sign to elicit in these people. Okay. No, go ahead, Yuki. Okay.
It was liver mass. We cannot get over the swelling of it.
Okay.
There was one question which Professor Ismail asked. What is this mass made up of? Is it a tumor mass or something else? Or what are the components of a mass even in a neoplasm?
The tumor, the overlying peritoneum, omentum, nodes.
Very few nodes in that area, no? And between the anterior abdominal wall and the stomach, you don't find nodes there, no? Yeah.
Dr. DT mentioned, can it be an exophytic mass from the liver?
It's moving with respiration, yeah.
Moving with respiration?
Yes, moving with the respiration.
Regulated exophytic mass.
But she was able to insinuate her finger, no? That's very unlikely.
Yeah.
What exactly? I think they want to be very clear about the insinuation of the finger.
Insinuation, yeah.
Yeah. Better will be if you are able to feel the upper border very well. It's very unlikely that you will be getting a very clear upper border in a liver swelling because unless it is a very tiny swelling, even then it will be difficult because it will be jetting from the liver surface. No, so to get a clean border, upper border in a liver swelling, is especially is unlikely because liver is still upwards. So that is actually the meaning. So if you are able to feel the borders, upper border very well. Okay.
What are the other signs of gastric obstruction?
Succussion splash is present.
Just
Now,
name
how
it,
do you
just
elicit?
name.
How do you elicit it?
The patient should be nil per oral for more than 4 hours and then keep the step over the epigastrium and shake the patient violently.
Oh, how does it come under palpation?
Violently. Oh God, you cannot shake the patient violently. That fellow will run away from the bed. Violently. Be very careful. So how do you elicit the sign? How do you elicit the sign? Sir has asked you that. What is the most important prerequisite before you do the test?
Patient should be fasting.
So that's first thing that you have
More
to tell,
than-
no?
More than 4 hours.
And then how do you elicit it? Doctor is asking you that
The
question.
stethoscope should be placed over the epigastrium and then shake the patient, or you can also hear the succussion splash even without the stethoscope.
That the patient will tell, no? That the
Yes.
patient will give the history that I feel some water as though in a water bottle which is splashing in my tummy. What are the other tests? So one is overnight fasting. Number 2, you said there's succussion splash. Number 3,
Scratch test,
crash test. Number 4, saline load test.
saline load test.
Yeah, so these are 4 of, there are one more test. There are 5 tests. Normally we don't do it, but some examiners may just ask what are the tests of gastric obstruction. Okay.
Scintigraphy, no?
No, clinical.
Clinical
Mm.
or bedside.
Now, bedside. Now, what is your DD for this mask? Just tell us. You had 6 DDs there. Now shortlist your DDs.
First will be a CA stomach.
Doctor cannot say CA stomach, doctor. 1 year history of vomiting and this patient with a succussion splash. How do you say it is a CA stomach? How do you say it is a CA stomach? When else can you get this firm hard mass? Can it be just a GIST tumor? GIST can present for a longer period of time, no? What are the other masses that can be present? That's what we are discussing. Can it be a leiomyoma? Can it be a GIST tumor? These are your differentials. CA stomach will never ever come as a DD for a 1 year history of vomiting, okay? Unless it was early gastric cancer and then it became a full-blown cancer. Even then, 1 year is too long a history. And with no macro and micronutrient deficiency, is it possible?
Nutritionally, they will be deprived.
He's not eating anything, and how is he not deficient in macro and micronutrients? How do you explain that? Is it partial gastric outlet obstruction?
Since 1 month, his symptoms was increased.
No, what I'm saying is 1 year history of vomiting,
Yes, ma'am.
and there's no macro micronutrient deficiency, right? Is it possible?
There is macronutrient deficiency.
So
No
you
evidence
mentioned
of
in your findings in your general examination, you said there's no macro or micronutrient deficiency.
macronutrient deficiency is there.
What macro?
His BMI is low.
BMI is not
Protein.
macro. What is macro?
Carbohydrate, protein, and
So which deficiency does he have? What
Did you
was the
objectively
frailty index?
assess it? That's the question.
What was
body
the
mass
frailty
index.
index? What was the frailty score?
frailty score I have not calculated.
Okay, now give your DD. DD, you said is CA stomach, number 1, number 2.
Exophytic gist, leiomyoma.
Why do you say exophytic? I say it is intramural. Why do you say it's exophytic? It can be endophytic, it can be transmural. Why are you using the word exophytic?
In fact, in here in description, she has written subserosal.
And that too
gist.
subserosal. Those will never present, they'll present as lump. They'll never ever present as gastric outlet obstruction, a true serosal. It has to be a mixed, if at all, it's a gist. What's the difference between gist and leiomyoma? Anyone else? Krishna Kumar? What is gist and what is leiomyoma? What are the cells of origin of leiomyoma versus gist?
Are they same? Are these tumors same?
What is interstitial? What is interstitial
What is the
cells?
full
Shahal?
form of gist? What is the full form of gist?
Gastrointestinal stromal tumors.
That gives the answer, no? So, stroma is made up of what?
Mesenchyme.
Interstitial cells of Kahal, no?
Yes.
And leiomyoma is smooth muscle. Please know all this.
Where do you find leiomyoma most?
Esophagus.
Esophagus. Okay. To some extent in the duodenum also possible.
So your
And
DD,
most of the other
DD
sites
here
it is
would
gist.
be, DD here would be adult hypertrophic pyloric stenosis will come as number 1. Number 2 would be a gist tumor, which is actually mixed tumor, or any other benign tumors. Can be any of those.
Can it be slow growing gastric tumor?
CA stomach, I've never seen person surviving for 1 year before.
1 year without treatment.
Because
And
slow
without
growing
treatment,
flat type will
Without
not
treatment,
produce
no,
obstruction.
no endoscopy for 1 year, nothing done. Patient is doing well.
He's from Kochi, is it? Is he from Kochi?
Yes, sir, from Kochi.
Kochi running around for 1 year without even an endoscope and all. That looks very.
We'll at least go to, I know, I agreed. We'll at least go to a government hospital for an endoscopy.
Kochi is the place where you have maybe around 50 and gastroenterologists, no? 50 or 75.
Yeah.
Okay, let it be like that. We will. I think we will ask them to how to investigate and then look at the interpretation.
Yeah, investigations. Let's see the investigations. Yeah, go ahead.
What are the investigations you need, Krishna Kumar?
Parag.
Yes, sir. For this patient, since the history is of from 1 year,
No more discussion. Just list out the
Just
investigations.
while we investigate, what will you do?
investigation
expect?
for management, sir, I would like to do a complete hemogram. I would expect low hemoglobin in this patient. Apart from that, I would do a electrolyte sodium and potassium. Since he's having persistent vomiting since last 1 year, I would expect hyponatremia in this patient. Apart from that,
What will happen to the chloride? And what will happen to the bicarb? What is alkaline type?
chloride will be less, ma'am.
What is alkaline type? What is alkaline type? We discussed this earlier also. What are the two things that are happening? Ranveer has discussed this so often. What happens
Is it
in the
just
circulation?
hyponatremia or something else will be there?
Chloremic acidosis, sir.
Hypokalemic metabolic alkalosis.
Acidosis?
Hypochloremic metabolic alkalosis.
Alkalosis. Yeah. Why alkalosis?
Loss of Cl, loss of chloride in vomitus. There is
Yes.
paradoxical acidity.
It's not chloride.
Hydrochloric acid is lost. Hypovolemia is there, so renin aldosterone system is stimulated.
There is paradoxical loss of paradoxical aciduria is there.
So it is basically alkalosis, hypochloremic alkalosis. Okay, agree. Parag, continue.
Yes, sir. I would check for a serum albumin level, sir. Apart from that, for diagnosing the patient, would like to go ahead with the upper GI endoscopy.
How will you prepare the patient?
We'll put a Riles tube, ma'am, and keep in a continuous drainage overnight. And we can even give a saline wash, ma'am, through the Riles tube.
What are the problems you're likely to encounter during endoscopy in this patient?
Due to the accumulation of the fluid in the fundus, ma'am, the chances of aspirations are there. So we'd like to intubate the patient and secure the airway, ma'am.
Intubate for this patient. Intubate this patient, is it?
Every gastric outlet will intubate.
So for securing the airway only.
Securing airway. What are the other things that you're likely to encounter while doing the procedure of this patient? When you do the endoscope and you pass the scope, what are the things you're likely to encounter?
One is in the due to the stasis in the esophagus, will see stasis ulcers, ma'am, due to the stasis esophagitis.
Carry
Okay,
on.
severe esophagitis.
Carry on.
Apart from that, in the stomach, we would like to see the distensibility, whether the stomach is distensible.
What are the chances that you may not reach the pylorus in this patient?
Yeah, you may not see the thing. You may not.
What are the chances that you may not be able to see and reach the pylorus?
Possible, ma'am.
No, tell why. Why?
Since he is having gastric outlet obstruction, ma'am, that means the tumor has grown large enough.
Tumor has grown large enough. It's not that. The stomach will be
Visible-
hugely
visible-
dilated. Stomach will be hugely dilated. Your scope may not reach there. Therefore, you may have decompressed the stomach for even 48 to 72 hours.
Yes, ma'am.
And there can be food stasis.
Yes, ma'am.
Okay, Ismail, please take over. When something is given, I keep asking questions, but
Yeah,
just
okay,
hold
good.
on.
Jovita,
Just hold on.
I think we can, what are the things you found, Jovita?
The investigation hemoglobin was 13.5.
Okay, just put it, show the slide,
Yes, it's
but I can read it out.
Currently,
Just put the,
You are
investigation.
not able to, is it?
they are not able to see. Jovita, please change to the,
hemoglobin. So is it visible?
no, just click on the
That slide is
investigation
not
slide.
visible.
Click on the investigation slide.
With the mouse, you click on that slide.
Slide number 14.
On the left side, you can click on that with the mouse.
And click. Is it visible, sir?
No,
Is it visible now?
yes.
On the investigations, hemoglobin is 13.5. Total counts are 6,800.
13.5. 13.5.
1 year omitting, good.
Uh-huh.
Then, okay.
Hyponatremia is 0.27. Potassium is 3.8. ABG showing alkalosis of 7.5 with a bicarb of 30. LFT,
7.54 is alkalose, is it?
yes, sir. LFT is
Bilirubin.
bilirubin is 0.5. AST
Yeah.
is normal. I think 3.3 is albumin.
Albumin, yeah.
INR is normal. Renal function tests are normal. Lipase is elevated 425. Chest X-ray and calcium levels are normal. Sugars are normal.
Comment on lipase.
Why is the lipase high? Did you do amylase also? You did it, is it?
Yes, sir, 96.
Amylase and lipase. Well, any reason? I think there is even people say that doing amylase and lipase is not indicated many a time. Even when a person comes with acute abdominal pain, it is said that it is enough if you do a lipase alone, because amylase may not be necessary. No, so I think what may be the reason why the lipase is high in this person?
Gastric source.
Where all will you get lipase from?
Can I share the screen now? You can stop sharing, Jovita?
You can just overwrite, sir.
Oh, right. Yeah, okay. Okay, now see the thing now.
No, it's a previous.
Lipase. You know that the pancreatic enzymes can be elevated in the absence of identifiable disease. Hence, estimation of these enzymes without a valid reason is to be discouraged. This is the up to date. So I think that just don't do lipase and amylase or all cases, even without valid reason, it can be elevated. And then what are the source of lipase? Do you know from where lipase is produced? What are the source of lipase? Parag or Krishna Kumar, do you know from where? Now the source it can come from pancreas. There is a lingual lipase, hepatic lipase, intestinal lipase, gastric lipase, and lipoprotein lipase is there. So lipase comes from a lot of sources. It is more than 3 times elevated in renal failure, macroliposemia, you know about macroamylasemia, acute cholecystitis and malignancy. It is more than 3 times elevated, and this is more than 3 times elevated. So possibly that may be one of the clues to indicate that this may be you are dealing with malignancy. There are many other causes like HIV, HCV, and all those things. But I think see that there is an idiopathic cause also. So I think this possibly it was not indicated to a lipase in this person, amylase and lipase. Okay, that's what I wanted to say. You can share your slide. Okay. Okay, so I think the lipase in this case may be because of malignancy. It was there. Okay. And 13 grams hemoglobin is also, I think, very Very high. Let's see the other one. Let's see the other slides.
Is it due to hemoconcentration?
Oh, yeah, that's a possibility. Yeah. If he's having severe vomiting, yeah, good. That looks like one of the PCV. I think what is the PCV? Is that?
It's around 40,
That's all.
40, yes, 40, 42.
That's all. Okay. Okay. Go ahead. Anthony.
The ultrasound abdomen was done.
Yeah.
It showed pylorus and distal body of the stomach appeared to be uniformly thickened with maximal wall thickness of 1.4 centimeter. Liver, gallbladder, pancreas appeared normal. There was no ascites.
Yeah.
This was the endoscopy finding. Not that clear.
No ulcers or anything, is it? The mucosa was smooth. No
Mucosa
Is it is it
but it
stomach
was
or esophagus?
stomach, sir.
stomach.
That's
Antrum,
5% antral region and the pylorus that's being seen. There was reduced distensibility. Distal body and antrum showed erythematous nodular mucosa with absent peristalsis and poor distensibility. Features seem as to be worsened as coke was passed distally, and on biopsy it was firm to hard, and D1 could not be entered.
What do you
Very
mean by that? Which features seem to be worsened means? What happened?
It was better distensible above, and while passing distally, it was not poor distensibility was increased. And then-
Maybe he's meaning that it is getting tightly narrow. Is that what he meant?
That's
Yes, sir.
maybe. Okay, go ahead. Anything else?
No,
Next
let the
thing-
other person interpret. Krishna Kumar.
The contrast CT abdomen with the arterial face showing thickened gastric enhancement of the gastric wall. There is mild mucosal enhancement. is there.
With this stomach that you see on the CT, can this person have a large voluminous vomiting?
Yeah, it looks so.
Yes, can the person ever have a vomiting or large
ML
volume
to
vomiting
Do you
in
have
this
more
patient?
CT films, Jovita?
And
this one?
ball rolling movements?
Yeah. And 300 ml, I think, yeah.
Maybe this is the proximal cut showing distended stomach
Yeah,
with
the
the
fundus.
food contents.
It was the fundus which produced the suction splash and ball rolling and all those things. That okay.
Any other films?
Only 2 films, sir.
Okay.
This is your case, is it? It was in your hospital?
In our hospitals.
Yeah. Because it looks so interesting and then it raises a lot of questions, such a long duration and then. Okay, go ahead. Explain the thing.
CT showed diffuse homogeneously enhancing circumferential thickening of the body and pylorus of stomach with significant perigastric fat stranding, perigastric lymphadenopathy, and query-omental deposits. Mild wall thickening along the proximal D1 and D2 of the duodenum. Mild ascites, features suggestive of neoplastic etiology. A relatively hypotense area in segment 4B of liver, likely focal fatty infiltration, small left renal cortical cyst.
Just go back.
Where is
Just
the
go
CT?
back on the CT. What about this D1 and D2?
Collapsed.
No, the report shows the thickening of the D1 and D2.
Is it?
So in this situation, you get extension of the thickening of the stomach into the duodenum.
Gastric lymphomas.
What about CS stomach?
Usually adenocarcinomas won't cause cross pylorus to duodenum.
Yeah, they respect the border for I don't know for what reason. Are there any explanation for that?
The thickening of the D1.
No, usually the adenocarcinoma of the stomach usually don't extend to the duodenum. But if you find an extension to the duodenum, it is typically considered either as a lymphoma or some other inflammatory process.
Yeah. Possibly, I think the same stomach
That's
is
the same thing.
acidic, whereas duodenum. So things which grows in an acidic environment may not grow in the duodenum. That may be the one of the explanations for that. But these are on the walls, it is not in
Yeah.
the. Okay.
So what is the sum total of the CT, Krishna Kumar?
Sir,
What is the overall inference after seeing the CT?
there is diffuse circumferential thickening, the gastric wall, the loss of rugal pattern,
Which
involving
part?
body and pylorus of the stomach.
Okay, so that is the involvement of the wall. What about the other findings?
Homogeneous enhancement of wall thickening noted and appears to involve all the layers of the stomach wall. Few areas of mucosal ulceration, significant perigastric and omental fat stranding, multiple rounded homogeneously enhancing lymph nodes along the left cardia, lesser and greater curvature, pylorus and peripancreatic region. Largest 17x9 mm. And few small heterogeneously enhancing foci in the omentum, omental deposits. Few subcentimetric nodes along the celiac trunk, SMA, postcaval and left para-aortic region, query involved. There is also thickened pylorus is abutting the medial wall of GB and left lobe of liver. However, fat planes appear maintained. Posteriorly, it is abutting the head and body of pancreas with focal loss of fat planes. Anteriorly, it is abutting the anterior abdominal wall with maintained fat planes. With minimal soft tissue stranding is noted along the left gastric artery. Mild wall thickening noted along the proximal D1 and D2 of the duodenum. With maximum thickening 8 mm, no evidence of any bowel obstruction or abnormal dilatation. D3 and D4 appears collapsed. Mild free fluid is noted in pelvic cavity. So this is a gastric tumor involving perigastric lymph nodes with
And tuberculosis?
It's involving throughout all the layers of stomach, ma'am.
Stomach and quite extensively also, from the body and from everything is thickened.
One of
But
the
how will you
DDs
explain the fat stranding and all, unless it's inflammatory?
Inflammatory. So I think that it looks, let us see the histology report. You're discussing it, Javida.
Yes, sir.
What does it show?
Histopathology shows signet ring cells, poorly cohesive signet ring cells. Polypoidal gastric antral and body mucosa showing irregular foveolar lining with tortuosity, edema and focal activity with neutrophils. Mild superficial inflammation mediated by lymphocytes and plasma cells seen. Mild mucosal eosinophilia. Fragment showing infiltrative neoplasm composed of discohesive atypical glandular cells with signet ring cell forms. Associated edema in inflammatory response. Poorly cohesive carcinoma, signet ring cell type, diffuse gastric carcinoma.
Diffuse, okay.
So
Mucus.
we should cover the management. Seldom we cover the management, no?
And I think the staging will be, there is the outside the mucosa, it's not involved, and outside the serosa, it's not involved.
Krishnamar staging.
This also they have mentioned that it is the fat plane between the stomach and pancreas got abutted.
It is extending outside the serosa.
Yes, sir. It's body of pancreas with focal loss of fat plane between the head and body, stomach and head and
So
body.
it is T3, is it? T3 or more than T3? Because it is. What do you think about the tumor staging? If it is
Stage T4, sir.
because outside it has gone
Outside the stomach, other organ involvement,
Yeah.
adjacent organ involvement.
And the N, there are only 2 or 3 nodes, How many nodes are there?
Perigastric lymph nodes, peripancreatic, and
Hmm.
also they have mentioned celiac trunk, SMA, postcaval, and para-aortic region.
Those are subcentimetric, no?
Oh, okay, sir.
We will, for the time being, consider only larger ones. So what will be
Omental
the
nodes are there.
omental?
Nodes
And
are there.
omental deposits also they have mentioned, sir.
Omental deposit. So what will be the staging? T4N.
T4, M1, N.
I think for gastric, one has to know the various stations of lymph node, because when you do surgery, they actually dissect out these lymph nodes and separately and send for biopsy, because to know how much extent it is really involved. Okay, so there are
You
different
should
stations.
also know. You should also know
Yes.
the lymphatic drainage of stomach.
Yeah, lymphatic drainage, the various lymph node stations you have to know. Do you know that?
Yes, sir.
Can you tell?
D1 is from N1 to node station 1, that is along the lesser curvature 1, 3, and 5. Along the greater curvature, it is 2, 4, and 6, with 7, 8, 9 being.
Those are stations. You have to
Yes, sir.
say where the lymph nodes are draining from.
Lymphatic
Sorry.
drainage. Those are the stations which surgeons usually mark and send the biopsy separately, because you don't take all the lymph nodes and put it in one bottle. You send it separately to know how much extent the lymph nodes are involved, and then they plan treatment accordingly, chemotherapy and other things.
Yes, sir.
Professor Ismail was asking you about the lymphatic drainage of the stomach.
Not sure, sir.
Parag,
Sir, left and right gastric lymph nodes, sir, which will drain into the celiac nodes.
No.
so is it only just left and right? So it has got a lesser curvature, greater curvature, upper part, lower part, no? So it's all different. I think if you don't know offhand, I think you have to refer and learn it thoroughly.
The lesser
Because
curvature will
this
have
will
left
be
and
asked in the
gastric.
examination, especially with the
It's
lymph
even
node. Yes, Professor Ismail.
no. It is even a theory question actually. The lymphatic drainage of stomach.
Yeah, it could be a short note. Lymphatic drainage of the stomach,
And you
lymphatic
should
drainage
also,
of the esophagus, all could be short notes.
but also you should know about the D0 dissection, D1 dissection, and D2 dissection. Basically, depending upon the stations which you cover.
You will be asked to draw in practical. That's what Dr. Jayanti writes. Will they ask you to draw in the practicals? They may.
Yes, sir. Yes, sir.
Yes, sir.
Is it?
Yeah.
You have to draw the thing. Okay. Okay. Okay, then. So
Management.
there are different approaches. Some people go chemotherapy first and then surgery. Here, is it surgery?
Krishnamar, no? You have to discuss.
Yes, sir. Since this patient is
We will
having
discuss Parag or Krishnamar. Krishnamar, you have been discussing the CT. So Parag.
Sir, the stage appears to be T4, sir, with metastasis on the peritoneum. So either palliative therapy can be given, sir. Palliative chemotherapy.
What is the patient concern? Why is the
But
patient came to the
patient is
hospital?
symptomatic of gastric
Obstruction.
outlet
Why did he come to the hospital?
For vomiting, sir. Weight loss.
So you have to relieve his major symptom, no?
Yes,
So
sir.
that is the most important. Plus, you have to treat as per the diagnosis. So how will you do that?
One thing is the scope could not be passed, sir, beyond the middle body or the pylorus. We would like to pass a guide wire if it's possible, and over that we can try putting a stent, sir, self-expanding metal stent as a palliation, sir, for vomiting and feeding purposes. If it's not possible for feeding, we can do a feeding jejunostomy.
Okay.
Why not gastrojejunostomy?
Yes.
Why can't you do a PEG? You have endoscope with you. You know how to do PEG.
Yes, sir.
Why can't you do a PEG?
Endoscopic gastrojejunostomy will be a little difficult, sir, because
that is PEJ. I asked you PEG. You may be thinking I am a foolish fellow. But this sometimes the students such a problem answers in that. So we are going to bypass the antrum. So there's no point in doing a gastrostomy, no?
Yes, sir.
It has to be gynostomy. Some people do endoscopic gynostomy and all, but it is not done in most of the centers. Only very few people do that.
Can PEG produce pyloric obstruction? Anyone? It was described that sometimes when Foley's catheter instead of the classical PEG tube, it can migrate and produce a gastric outlet obstruction. There are case reports of when Foley's catheter was used as a PEG tube, migrates and producing a gastric outlet obstruction. Okay, go ahead.
What else? So you have put a stent.
Yes, sir. Palliative neoadjuvant chemotherapy can be given, sir.
Does the patient
Yeah.
pain?
Why you said neoadjuvant?
I didn't mean neoadjuvant, sir. Palliative chemotherapy can be given, sir, to reduce the muscle.
So when you send, so in that case, when you send the biopsy, will you ask your pathologist to do something else?
Yes, sir. We'll ask for HER2 new mutation, sir.
And what else? You have to send for microsatellite instability also, MMR, mismatch repair gene
MSI.
mutation also. IHC you can advise because usual chemotherapy won't act when you have a MMR mutations.
Yes.
Yeah, if the patient is affordable, you can even send for PD-1 ligand mutations, basically to know whether immunotherapy will work or not.
Yes.
Anything else, Professor Ismail?
Yeah, I think can I ask a quick quiz for this thing? Quick quiz. Oh no, that this shows that US may not be that useful. How can multiple myeloma produce gastric outlet obstruction? It produces a diffuse infiltration. Suppose multiple myeloma produce diffuse infiltration of the cell. It is due to amyloidosis. No, anyone knows what is Bourg syndrome?
Gallstones causing gastric
Yeah,
outlet.
gallstones causing. Yeah. Next one, I will ask Joe to answer. Jovita to answer. This is gallstone producing gastric. Who is this lady?
Rapunzel.
Eh?
Rapunzel's
What has she to do with the gastric outlet obstruction?
trichobezoar.
You okay? Oh, you all know these things. Rapunzel syndrome. Yeah.
Rapunzel syndrome.
Okay then. Okay. Okay, I'll stop sharing then. Okay. Anything, Ismail?
I think we had a disconnect between the history and the final observation.
Final.
History, physical finding, and the final diagnosis. So how could this have happened?
Next time, the person who's presenting, the discussion will be by the other participants, not by the candidate, okay?
Yeah, because she knew the diagnosis.
Yeah,
That's
and
why I
she's not
think
able to think of anything out of the
anything
box.
else, and because that's not
Yeah.
correct,
This is a problem which we always say. If you get a tip, you will hover around the main diagnosis. You will not
She's
go a
worked
little
backward.
wired this way or that way.
Yeah.
And
she's
examiners can easily sense it. Because
She's
examiners are seasoned people, they can easily sense it. This is, I would rather call helicopter syndrome, because the diagnosis will not move farther away. You just hover around the same diagnosis again and again. You will be given a chance to offer other diagnosis, but still you will not do that. Okay,
This
so
is,
we are not
your
finding
term,
faults.
this
Once you get
helicopter
biased,
syndrome.
the mind will not work. That's the issue.
Helicopter syndrome is a word coined by you, or it's something which everyone knows about it? I am hearing it for the first time, I think.
Hovering helicopter above your head.
Oh, yeah.
BT, next time onwards, let the candidate present, but there will be no discussion by the candidate.
There will not be any
And-
discussion by the
and-
person who
and-
is presenting.
Yeah, that person has to just do the job. It's difficult for us as faculty we used to do it,
Yeah,
We
yeah,
used
I
to
think
prepare the slides. Now it's beyond our capacity to make slides and do all this. So let them one person takes the presentation. Next time that person can take up the discussion, no problem. The next time she can take up it. So just do that. Let it not be, because here and the candidates to their own conscience should not discuss and find out what is the case. I mean, there's no charm in that. The diagnosis, you cannot discuss this as CA stomach as your first DD, okay? I can guarantee that you will not get through. I'm very clear about it, okay?
Yeah.
And the first impression, the examiner will say, oh, you've got the flu, and that's the end of the story, there'll be no movement forward. So I think to avoid all this confusion, supposing she has to present, she presents with other 3 people take over for the discussion. And next time that person who's presenting comes in, so that the rotation goes that way, okay?
Anyone from the audience would like to comment anything, or any burning questions or anything?
Jayanti ma'am has put something in the comment box about other thing. Can you just say that? HER2 mutation.
Yeah, HER2 mutation, this is that they have this trastuzumab, that as a treatment protocol for management of these advanced cancers. There are all these new things that are happening. And I don't know what all written something a bit in there. The next one was types of the Lawrence classification, the diffuse type and the local type. The two types that is known in histological classification. This was known in our times, and it is also now. 100% there will be a discussion on H. pylori, okay, H. pylori and eradication. You must know the Corey's hypothesis of H. pylori as a carcinogen. So all these things are the other questions that can be asked. This question which I had mentioned about the drawing, you will be asked to draw the lymphatic drainage of the stomach in front of the examiner. And this was a short note in the last exam. The previous exam, it was a short note. Okay, I think
Jovita has made a good presentation. That presentation was good, but for probably the negative thing was a little too much, which could have been sort of curtailed.
what
But
I'm
otherwise,
saying
it
is,
was a good presentation.
the thing is, no, I think VT, I mean, I believe in being, let them learn from all these sessions. There's two things that are incongruous, the ball rolling movement and then large volume. Okay, it's just not possible. The person cannot eat so much, no? The person cannot eat. With early satiety will be there. Even if the fundus is usually dilated, he cannot even vomit. The vomit symptoms itself, it's not possible because the stomach will be full of food. And he will not be able to eat the next meal. So you have to be very clear about this. And don't mention about the mass moving from the head down, moving up and down, and finger cannot be insulated. And the other question that is asked, which Dr. VT mentioned, was what are the components of this mass? So you can have the mass per se, it can be a fluid, it can be omentum, it can be nodes, it can be the mesentery that is overlying that particular organ, or it can be a local perf with a perigastric abscess. All these constitute a mass. Two situations when they ask for a mass, one is this components, other one is CA colon, the sigmoid. When you have a mass, the left iliac fossa and SCA retrosigmoid, what are the components of the mass? So just remember, these are all standard, okay? We cannot change questions. No? Medicine is just
this is a standard question. Components of a mass, especially if the luminal component is small and the clinical component is high, this question will immediately come. What are the other components of the mass?
Medicine,
I think we have to have the final comments from our respected faculty. Narendra sir.
Pardon? Yeah. I think on the whole, I think the discussion went on. I think you presented it well, but I said there are certain things which you may take care of in this thing. And what happened in this case was that because the presenter knew the diagnosis, the differential diagnosis came down because no one would make a first diagnosis of carcinoma stomach with a 1-year history. And but I think finally it happened to be true. No, finally I think the impression was right that this person had carcinoma stomach. And what happened to the patient? Any follow up on that? What happened?
After the surgery consultation was done, this palliative planning, sir, discussing with the patient. They were not financially affordable.
What palliation? What was a palliation? Feeding digenostomy.
Feeding NJ tube.
Put a tube.
NJ2.
And did they put that stent or something?
They were not willing for stenting and all due to financial constraints, sir.
NJ tube also. NJ tube will pass through this, is it?
Sometimes with the guide wire, you may be able to pass the trials tube. Like you may be able to with the guide wire through over the guide wire with the pediatric scope. You may be. Yeah.
Professor Ismail.
Adult hypertrophic pyloric stenosis is a good DD, okay? It's a very good DD for this patient.
Professor Ismail is there?
Yeah, sir is there.
You are muted.
Sir, you're muted, sir.
You are muted.
Ismail, your comments.
No, this is a classical exam case, gastric outlet obstruction. So you have to know in and out of gastric outlet obstruction, and the discussion should be there should not be any anything wrong from your side, because if you have a case, it will be there for the exam.
Any other things they should know, sir? Anything else they should know? The drainage, the left supraclavicular lymph node, they'll ask you to trace. They'll ask you to trace a path into the left supraclavicular. And actually it's a misnomer. It's only a subcutaneous tissue that is clogged with the tumor cells. It's actually not a true node. Sir, Dr. Narendra, sir, you would be knowing a little bit history about that. They always say it regurgitates. You know,
It's
the
a Burkos
left
node, eh?
yeah, the Virchow's is actually the lymphatics that the tumor cells that regurgitate at in the thoracic duct, you know, and the subcutaneous tissue there, along with that tumor cell, acts as a so-called quote unquote a node.
So-called
But
node.
Yeah, but there is no actual node there. It's a Gordas, I remember him telling this, but I stand to correction. Someone can just look up the history and just ensure whether that is a node or what I'm trying to say, because I heard this in one of the sessions, that it is a tumor cell which regurgitates to the thoracic duct just at this point of entry in that subcutaneous plane, that along with the tumor cells, with the subcutaneous tissue, looks like a node and therefore it's called a Virchow's node. But just look up again for clarification.
And sign is called Trousius sign. And
Yeah.
you also can have anterior axillary nodes, Irish nodes,
Irish nodes.
which goes through the abdominal wall actually.
Two questions. What is Tabes mesenterica?
Tuberculosis.
Tuberculosis.
Tabes.
Tabes mesenterica. Jovidar said something. What was it?
He knows it's something to do with tuberculosis.
Yes, you are
It's rolled
correct.
up. It's a rolled up mesentery.
Large.
It's more seen in children, pediatrics.
What is pseudopylorus sign?
Due to the ulcer, the constriction of the lumen actually causing false appearance as it as pylorus. Actually, behind that lumen is there, not duodenum.
Yeah, what's the relevance of that? Because the management of duodenal and gastric ulcers are different. In very often, in I think 95 to 99%, we don't take biopsy from the duodenal ulcer because we presume it is a benign condition and it is benign. Okay. But in gastric ulcer, we always take biopsy. So if we think that the pylorus which we saw is the original pylorus, we may completely misdiagnose a gastric ulcer as duodenal ulcer. So one must be aware of this possibility. Okay, especially in gastric ulcer, early gastric malignancy or the andropyloric region, this may happen. Pseudopylorus sign.
Okay.
Okay, anything else to discuss?
So, yeah.
Can we
Okay.
wind up the session?
Okay, we can close the session. Okay.
Okay, Dr.
Thank you
Jerry.
very much, sir. Thank you.
Thank you.
So thank you. Thank you very
Dr.
much.
Jerry, are you there? The coordinator? Okay, he doesn't seem to be there. So on behalf of ISEK, I thank Narendran sir and Professor Ismail for sparing time to be with us to teach the students. I am sure they are immensely benefited by your wisdom. And I thank Jayanti ma'am also for joining us. And we look forward to your continued cooperation in future. I thank the presenter as well as the discussion. And please remember, okay, Jerry is there, complete.
Some online issues, sir.
Okay, it is your privilege.
On behalf of presidents, I extend our sincere gratitude to our lead faculty, Narendra sir, for joining us with the discussion and bringing up illustrative slides for helping us with the discussion. I also thank Ismail sir for joining us lead faculty. I also thank the moderators, Jayanti ma'am and Varghese sir, for leading us through the discussion. I also thank the IST coordinators for making this venue for us for discussion. I also thank the volunteers.
Thank you and good night.
Thank you.
Okay, we have a class on Thursday.
Jovida, Krishna Kumar,
I'll have to just check out.
What is the class?
I think they'll all be going for the Endocon. I don't know.
Okay, okay. So from ISGK side, we have a class next week, Tuesday, 8 o'clock.
Yeah, I
Okay,
think next week we'll also have on Thursday.
okay,
I
fine.
think they're all traveling on 6th, no? 7th, 8th, 9th is the.
Yeah, conferences after conferences. We can't sit at home.
Yeah.
Okay.
Okay.
Good night, sir.
Thanks
Okay,
a lot.
thank you once again, Narendra
Good
sir.
night.
It was a pleasure. to-
Good night, sir.
Good night, Dr.
Thank you
Ismail.
for giving us this.
Good night. Good night, ma'am.
Good night, sir. Good night.
So I am
Thank you.
ending. I am going to switch off.
Yeah, good night, VT.
Good night.